Welcome everybody. Welcome to today's meeting of the Joint Integration Board or Integration Joint Board. My name is Brian Jones. I'm Executive of NHS Tayside and the chair of this meeting. I'd just introduce Colin Stewart, Vice Chair, Jackie Pepper, Chief Officer, Donna Mitchell, Chief Finance Officer, Jeff Steele, Doctor to the Board, and Scott Henry, Demographic Services Manager. Yes, now if you confirm if there's any apologies.
Of course, so we have final apologies today from Heather Dunn, Keith Russell and Monica Doyle. We've got one update to the membership, which is Rachel Smith is joining as the private sector representative and she's online today.
Thank you. Can I also remind those joining us virtually to use the chat box to attract any attention during the meeting? Thank you. Number 2, declarations of interest. And ask anybody if there's any declarations of interest in respect of the business on today's agenda. Moving swiftly on, minute of the previous meeting, the 20th of August. We agree the minute from our last meeting. Read. Yeah, great. Yeah. Action point update, Chief Officer.
In terms of the action points, update you can listen a date for a joint session on the Tayside Neighbourhood of Learning Disabilities and model of care for general adult psychiatry. I'm trying to hold that with the attendance of both Dundee and Angus IGB members as well. In addition, members will also note that Angus Health and Social Care Partnership are seeking to have a session in relation to their out-of-hours services reform work, and it looks quite difficult to achieve. So we're going to try and cover both of those items at our development session on the 24th of October, but we may not be joined by other IGB members. In addition, there's a session being offered for the 23rd of October for the out-of-hours reform work. I know that there's quite a number of our members en route to join that, so we're hopeful that we'll cover that on the 28th of October. That's in your diaries already.
Thank you. Any matters arising from the minute or action points?
In terms of the matters arising, really just to say that the new providers for the GP practice at the CARS that has now transitioned on the 15th or 16th of September. And that's successful, but perhaps please will pick up a bit more detail on that in the friendly papers.
Thank you. Ladies and gentlemen, we're going to move the agenda slightly around to bring finance forward after the strategic update. So after 6.1, we'll go into the finance paper. On paper 6, delivering on strategic objectives, and ask Chief Officer to give a verbal update, please.
Yes, thank you very much. I'm noticing that some people may not be able to hear us online, so I'll try to speak loudly and clearly. The first area that I would like to update you on is the out-of-hours reform, out-of-hours GP services reform work that's underway, and IGB members will receive a briefing on that. That briefing was also issued to elected members of the 3 local authorities and MSPs and MPs. This is a service, as you know, that is delegated to Angus IGB but operates Tayside-wide, and there is a base at PRI from which the service operates for the Perth and Kinross population. And really just to confirm for IGB members that we have staff within the HSAP, including Hamish Dougal as Clinical Director and Dr Sal Peterson as our lead GP, are directly involved in the work associated with that review. And as I said, there's an online development session planned for IGB members. Over September and the week beginning the 8th of September, Learning Disability Week across the UK was celebrated, and teams across the Health and Social Care Partnership were involved in a number of themed activities and based around I Am Here, Include Me, as a powerful message about visibility, voice and inclusion. And the Health and Social Care Partnership highlighted and is focusing on the key issue that people with learning disabilities can find it more difficult to find work and earn money, and are often excluded from community life. And have engaged in a survey across community organisations and individuals to ask a question about how confident community groups feel in supporting people with disabilities, and what support or resources would help to strengthen inclusion within their services. So the survey closed on the 30th of September, and insights from that will help us understand what's working well and what additional support might be needed. There were two lively events that I attended in the Civic Hall here in High Street, including a cake and tea afternoon with a wide range of participants, and the Perth and Kinross Employability Network hosted the Inclusive Employers Awards ceremony on the 12th of September with nominations from staff and participants, and it was a real privilege to be at that and to recognise local employers who are assisting people with a wide range of needs into supported employment, including McDonald's, Tesco's, Tayside Contracts, Push, PCAS and Perth and Kinross Council, amongst others. So the real difference that work is enabling people to have meaningful work opportunities was really great to see firsthand. And also in September, we had two ministerial visits. The first, on the 10th of September, the Minister for Public Health and Women's Health, Jenny Minto, launched the National Palliative Care Strategy at Cornhill and PRI. And the Minister visited the hospice care and related wards in Perth Royal Infirmary, meeting staff and medical personnel across the site. And in addition, we had staff and partners involved in the palliative care network for Perth and Kinross, and our local work here in attendance, and were invited to speak with the Minister. And I think we really demonstrated strong collaborative work in Perth and Kinross across all our teams and services on that day. We also had the Minister for Social Care, Mental Wellbeing and Sport, Mr Tom Arthur, attended the Nuke in Perth on the 16th of September on the day of the publication of the national data on probable suicides. And there was an invitation extended to suicide prevention staff and representatives of the three crisis hubs that we have in Tayside, the Nuke, Hope Point and the Beacon in Angus. And again, this was an opportunity to demonstrate how we're delivering for our communities in an easily accessible and non-stigmatised way, and the extent to which staff across sectors work across organisational boundaries in strong partnership was evident on that day. We have also finalised and commissioned some work from the Health and Social Care Alliance on an evaluation of our public partner recruitment process, focusing first of all on public partners for service users. And this work has involved and been informed by our 4 public partners, and is designed to identify good practice in areas for further improvement. And the review will take place over October to December, and a report will be produced by the end of January 2026. And thereafter we intend to include a similar review in relation to carers public partners. And I think we are the first IGB to carry out such an evaluation, and it's really important because this will contribute to not only our own learning about what works well, but fulfilling our mainstreaming equalities duties as well. So good to see that work coming to fruition. Thanks very much, Jim.
Thank you. Thanks, Jackie. Any questions? No? Oh, Martin.
Just on the strategic objectives, it's taken on board for myself, the understanding. Are the strategic objectives bring cognitions to the corporate objectives that NHS Tayside has? I'm thinking about the mental health, etc. because we in its gestation they have corporate objectives and outlines against each corporate objective. Do they help to develop the strategic objectives? The partnership.
I think the answer to that would have to be yes, Martin. Not in every instance,
No.
but and for quite a few of them. So if we take there's a corporate objective in terms of creating a less complex structure for mental health, as you outlined there, and we're involved in developing that work, and the work that Jane is leading for the Health and Social Care Partnership in relation to our local community mental health and wellbeing strategy will align with that.
Thank you.
Thank you. Yes, Sandra.
Thanks very much, and thanks very much for that comprehensive update, Jackie. I just wonder if where and when appropriate, if it would be possible for public partners, IDB public partners, to be included in some of the visits, such as those you've described when they're taking place. Some of the public partners are involved in the Tayside Public Partner Forum, and as part of that have been involved in the redesign of the palliative care network. So, for example, with that event, then it would have been really good to have been able to participate in that. But maybe moving forward, there might be opportunities. Thank you.
Just in answer to that, Sandra, happy to take that on board and think about how we can ensure that you are involved in future activities. With ministerial visits, there's very often a particular request to meet with a particular group of staff or engage in a certain way. So sometimes we're not necessarily always involved in that. But happy to ensure that it's stayed that as far as possible and include it wherever that's appropriate.
Thank you. Any other questions? No, thank you. There are no further questions. Can we note the verbal update, please? Thank you. As mentioned earlier, we're next going to move to the finance paper before we move on to Tayside Mental Health and Learning Disability Services. So I'll hand over to you.
Thank you, Chair. Good afternoon, everyone. You forgive me, my introduction to this report today is longer than it normally is, and I think that's important that I give as much information and context that I can for you to be able to consider today's report. This is our second financial report of the year, and it's given a forecast of the year-end position, and it's based on expenditure to the end of August, which is month 5 of this financial year. As agreed at our previous board meeting, this report also covers the work undertaken to prepare and implement a financial recovery plan. The report is now forecasting an overspend of £5,558,000 for 25-26. And of this, 4.4 million is in regards to social care and 1.1 million within health. This forecast overspend update is an increase of 643,000 since the last report. This increase is mainly due to increased demand and greater complexity and needs in older people's services and adult services, and particularly in care at home, residential and nursing placements, and new high-cost care packages. It's also through higher use of supplementary staffing within inpatient settings, mainly as a result of vacancies or sickness absence, but also an increase in our patient acuity. There's been growth in our direct payment support packages and our externally commissioned services, and that's particularly noticeable within our south locality. We've had rising costs for residential placements that are support individuals with learning disabilities, mental health and physical disabilities, and those reflect the increased complexity in existing packages of care. An increase that we've also seen is within our bad debt provision, and that is in line with wider trends that are seen across council services. These movements reflect the ongoing and unprecedented increase in demand for our essential services, which is now beyond what our current budget and our contingency can support. At the same time, there has been a continued expectation to both improve and sustain our level of performance, and this has resulted in additional financial pressures, particularly as we work to reduce unmet needs and minimise delays in patient discharge from hospital. It's important that I highlight that both the IGB and the Health and Social Care Partnership have delivered significant recurring savings over the past 3 years, totalling £12 million, with a further £2.5 million approved for delivery this year. These savings, totalling £14.5 million, have been achieved at a time of population growth and increasing need, and they've been recognised by Audit Scotland as significant progress on delivery of recurring savings. Members are aware that the annual accounts were submitted to the IGB's Audit and Performance Committee last week for approval, and the Audit Director from Audit Scotland attended that committee and confirmed and provided a clean audit opinion, and she advised that while that was a finding that we would hopefully have expected, it does provide positive assurance to the board, and it gives the public positive assurance about our use of public funds. And also that it was not to be taken lightly, and that it would reflect the quality of our financial management. The IGB's financial strategy, as you're aware, has placed efficiency and improvement first, only considering the reduction or prioritisation of services when all other options have been exhausted. We are now at a point where the budget is stretched to cover essential and statutory services or those that prevent the need for statutory intervention. Our funding is fully committed to unavoidable statutory services and preventative areas, and further efficiencies have already been realised or are already identified to be realised. And much of this is contained within that £14.5 million of savings that have been approved over the last 4 years. And that 14.5 million equates to 7% savings that have been delivered or on track to deliver in that period of time. So while improvements will always be required, and there are some additional improvements identified in Part A of the recovery plan in front of you today, but I would assess that the current level of expenditure is not a result of waste or poor management, but of unprecedented demand for our essential services. And those are to keep people safe, support carers, discharge patients from hospital and care for vulnerable adults. The demand for these services is growing faster than our funding. When the budget was set in March this year, we used the best available information on levels of needs and costs, but we built in contingency for growth and budgeted at a medium range level, while also highlighting that the potential impact of a higher need scenario could be likely. Had we budgeted for the higher levels of need that we are now experiencing, it would have meant diverting resources from other essential services or requesting significantly more funding from our partners in advance, something that was neither realistic nor justifiable at that time. But we are now facing a level of need that exceeds previous trends. Recent national reports that this board's considered in prior meetings from the Accounts Commission and from Audit Scotland confirm that this challenge is not unique to Perth and Kinross, but has been experienced in nearly all health and social care partnerships across Scotland. The scale and complexity of need is higher than previously identified, and this is supported by the latest population projections that have just been released by National Records of Scotland just on the 30th of September, and we've got a slide just after the report to show you. But these updated figures, they're based on the 2022 census, and they show that Perth and Kinross is experiencing a faster growth in its older population compared to the Scottish average, and confirms that the number of residents over aged 85 in Perth and Kinross has already increased by 10% in the last 3 years alone, and this will rise to 12% in just the next few months. This rise in Perth and Kinross' older population is contributing to more demand on our essential services, which increases the financial challenges that we are already facing. We will continue to refine our forecasts, but it's important to be clear that good financial management alone cannot resolve this situation. the actions required to reduce and prevent the expenditure forecast from deteriorating further this financial year. These are detailed in Part A and Part B of the Financial Recovery Plan. But before implementing these, in order to significantly reduce expenditure both in this year and recurringly, some of these actions will require careful consideration and assessment of impact so that it's fully understood by the board, our partners and the public. We need to recognise that there may be impact on our strong performance. This is something that's been reported throughout our Audit and Performance Committee throughout the year and acknowledged by Audit Scotland. We continue to be performing well against our comparator areas year on year, and we compare favourably against the Scottish average as well. Therefore, despite financial challenges, the outcomes for people in Perth and Kinross remain strong compared to the rest of Scotland. It's important to acknowledge that the proposed actions within Part B of the Financial Recovery Plan could adversely affect this strong performance. Given this potential risk, it is essential to evaluate each action to understand its implications and to understand what the compromise will be on our current success. I need to highlight that the IGB has quite recently set clear risk appetites for the main strategic risks. These include not just the financial risk, but also risks relating to performance and outcomes, as well as service demand and capacity. So when deciding on how to deal with financial challenges, these risk appetites must be taken into account to ensure balanced decision making that reflects all of our responsibilities. If we were to consider the financial challenge in isolation, it would be possible to reduce expenditure fairly quickly and considerably. However, we must balance any such decisions carefully, taking into account the potential impact on service users, carers, other interconnected parts of our health and social care system, and upon our statutory obligations. Therefore, recommend the board endorses the actions in Part A of the Recovery Plan, as set out in Section 5 of the report. However, I strongly advise that due to the potential impacts on services and performance, the actions in Part B are authorised to be scoped at this stage, examining the causes of these pressures and the impact the proposed actions may have. These actions need to be considered in the context of Perth and Kinross' shifting population, with that 10% increase in over 75 age group already experienced in the last 3 years, a further 2% in the next few months, and this is projected to have increased by 23% in just the next 4 to 5 years. The IGB has also had a recommendation from Audit Scotland as part of the annual accounts external audit. And this recommendation is that the IGB uses its strategic commissioning role to work with partners and other service providers and service users to accelerate service redesign and transformation to provide sustainable care. So given the significant impact these actions may have on strategic direction, I advise allowing sufficient time to fully assess and understand the implications of each proposed action, and while doing so, actively seeking in-year funding support to avoid the need for immediate implementation. Therefore, I advise authorising the Chief Officer to work with partners for additional in-year funding so that this work can be comprehensively completed and fully understood before decisions are made. Thank you for your patience and my past 2 years out, Jackie.
Yeah, thank you very much. Thanks for your introduction, and really just to say a few words to emphasise some of the points I think that you've already covered on it. And it's the importance of the financial recovery plan striking a balance between reducing spend and not compromising the legal requirement to deliver safe and effective care and support for vulnerable adults. And that's why the recovery plan is set out in 2 parts. Part A, which is focused on areas where the Health and Social Care Partnership with professional advice, we've already identified where we can further reduce spend. And the second part, which outlines a series of actions that we are currently looking at and working through. It's not that these are decisions that we're asking you to make now, but that there's likely to be a time lag in being able to deliver some of these if we are to take them forward, because we have to undertake various reviews and impact assessments that include the delivery, how these actions might impact against the delivery of the IGB strategic plan, how those actions might be assessed in terms of inequalities and fairness impact assessment. What that might mean in terms of medium to longer term impact on achieving outcomes for our communities. We would want to take legal advice and an assessment of our statutory duties, both as a health board and local authority. And there may be an impact on some of this on our continuing performance. And we now have Scottish Government that's predicated on achieving a certain level of performance in certain areas. So it may place that funding at risk. And also just to think about that wider impact on partners across the piece in terms of the impact on acute services and what that might mean in health and across housing, community and third sector independent organisations. So and just to be clear that the actions outlined in Part B are made as a request to the IJB to request a scoping and impact assessment to be carried out and to bring forward more details on each. And really just so that you leave without any doubt that our priority remains delivering safe, effective, compassionate care for our people and our local people, and we must deliver that in new ways, and we need to come forward with proposals around that too. But we must remain focused on sustainability and service continuity for those who need our services most. Thank you.
Chief Finance Officer, I think you mentioned about some slides.
Yeah, just Audrey, could we bring the slides up, please?
So the slides that we're just about to put up, this was just a couple of charts that illustrate the point we were making around the population shift. So this is based on the very new information that we've had from the National Records of Scotland. And what you're seeing here is the total population increase in Perth and Kinross projected over the next 20 years. When I was introducing the report there, I was talking about that we've already seen a 10% increase in our over 75 age group in the last 3 years. So that very early start to that curve that's already quite steep, that's all age groups. So if we were to draw that line for just the over 75s, you would see that a very, very steep gradient in that first box there. But this is to show how much our population is due to increase in addition to that of the Scottish average, and be mindful of that when we're discussing any decisions that will have an impact on our strategy or our direction. And if we pop to the next slide, this is just more information. So the last population projections we had were based on 2018 figures, and they're shown on the left-hand side, or the blue if you're seeing this in colour, and the orange or the right-hand side columns are the updated information. So if you look at kind of our key age groups around 1867 and upwards, you'll see that in each age group there was previously a projected growth, well, in the latter two. However, that growth has increased for the 18 to 67 fairly significantly, but if you see the age 86 plus, we're expected for that to grow by nearly 140% over the next 20 to 25 years, which is a far higher growth than we had previously been advised. And then the final slide is this chart, but in absolute numbers. So again, if we look at that over 86 population, so about 1,200 extra people that are expected to be within that age group, and based on the latest population projections, which in turn, and colleagues can explain this better than I can, doesn't inevitably have an additional pressure financially on our services. Just to give a bit of context too.
Thank you. Thank you. Any questions? Lindsay?
Good afternoon, everybody. It's just in regards to, obviously, well, first of all, Donna, thank you for the report. It's very realistic, and I totally understand that we are not the reasons for your long introduction. It's just on regards to the options or the things that you're going to be looking into a bit more. I'm just wondering, would both staff side, myself and Stuart Hope, be invited to have a conversation with yourself and Jackie in regards to the options that you're looking at? Because obviously it does mention looking at staffing of if you're over recruited, and I'm just a bit concerned about that as staff side.
Jackie?
Thank you very much, Lindsay, and I think you raise a really important point there in terms of your involvement, absolutely, where appropriate. And in terms of any impact assessment, I'm thinking about other partners, including independent providers, etc. We would be looking to ensure that we have a perspective from a whole range of stakeholders reported back to the IJB. So yes, a commitment to ensure that you're involved where there are implications for staffing.
Thank you so much.
Thank you. Martin?
Jackie, thanks for all the work you do, especially team and getting us to where we are. That what is concerning for me is the fact that there's a 10% increase expectation now. What SSID range does that sit under? Because for the difference from SSID 1 to going up the way, that there's a 12-year life expectancy for a woman and a 10-year life expectancy for men. So this seems to be coming in the category that these are the people that are going to live longer because they're in a higher SSID. So does that attract more NRAP funding, or is there a recognition that these people are because they're more affluent, they're more healthy? Does it come to the thing that because you get to 75 and above, and you're more healthy? So I'm not really knowing what I'm trying to say, but I'm trying to say is, where is the analysis of where this 10% growth coming in? And because if it's all coming in the SSID 1 in the poverty areas in Perth and Kinross, or is it coming across up to the SSID 5?
Finance officer.
I think they're all valid questions, Martin. So you're not sure you're going to ask it, but every one of them is a valid question, because we need to understand, is there going to be an NRAC or a GAE contribution that recognises that increase in population? And yes, that should follow through. Is there a change because of the deprivation factor? If there is a change in our deprivation population, absolutely that should follow through. But then there should also be an increase due to the fact that over 85 in itself should attract a higher weighting. So yes, through a distribution group that sits nationally, that should all be recognised. And I can only imagine, and I don't know this for certain, but these population updates will be filtering through for planning nationally going forward. In regards to where our 10%, and that was just me highlighting the over 75 part of our population. It was just to give an illustration of how much it's grown in the 3 years that we've been looking at a really financially challenging position. And in that 3 years, with that increase in population in an area where we know that it's more costly for us to provide a service for that population, we have made nearly £14.5 million worth of savings at that time. So it's the point of that won't be able to continue with an increase in population with the level of savings that we've already made. So we need to go and look at the analysis. As I say, this information just came out, well, it would have been this week, last week, losing my days, just very recently, and we need to get in underneath all that information to look at for Perth and Kinross as a whole, not just for the social care aspect.
Because there could be a 10% increase in population over 75 and they're all healthy.
Yeah.
Chief Officer.
Yeah, I suppose my initial response to that would be absolutely we need to look into this in a bit more detail, but I think what we're seeing in the figures are that people are living healthier, longer lives
Mhm.
here in Perth and Kinross. But when you reach 86 and beyond, then we all have an end of date, a sell by date.
We're in the waiting room.
Yeah, but once you're beyond 86, regardless of how healthy a life you've been living and have been blessed with, then the likelihood of requiring care and increasingly complex care grows. So that's where the financial challenge is going to be.
Thank you. Councillor.
Thank you. My question is based on the palliative care services. And it says that the Dundee Palliative Care Service is continuing to use supplementary staffing to meet staffing levels. Does this mean it's agency staffing? And if so, is there an overall figure roughly of how much is paid out to cover agency staff?
I can answer for in part, Councillor Frampton, because the Tayside Palliative Care lead sits within the Integration Joint Board. But across all health services, there has been a very aggressive, I think, attempt to reduce agency staff to a minimum. So the supplementary staffing will be likely to be less about agency staff and more about bank staff and when you need to bring that in. But I can't give you the level of detail for Dundee, but I can give you assurance that Dundee should and is likely to be as strong in its monitoring of supplementary spend as we are here in Perth and Kinross. But I couldn't give you the details to
That's fine.
that.
My reason thinking behind it was because I think even across the hospitals and whatnot, bank staff are used as well. And my understanding is bank staff are more expensive, to have. Are they not?
No. Bank staff tends to be, if you keep me right, bank staff tends to be on par with our employed staff. It's the agency that has that excess cost.
Yeah. So, right, okay.
Thank you. Any other?
You've got some questions.
Councillor McCall?
Thank you. Can you hear me?
Yes.
Good. So I have a couple of questions, if I may, or maybe it's just points to make. And tables A and B, or Part A and Part B, it would be helpful to know, perhaps when this is brought back, what the full year benefit might be, because obviously we're sort of a good bit into this current year, so I fully understand why there's only limited savings in current year, if any of these are there, but full year savings I think might be helpful. And the other question I have is, can I just see the previous slide that you had up on the screen there? Is it okay? That's not the slide I've seen. That's okay. No, that one, yes. So I'm just wondering if this increase in population is reflected in the other two council areas in Angus and Dundee. Does anyone know?
Yes, and we did look at that, and we looked at that when considering the same source of information. So while I wouldn't want to speak on Angus or Dundee's behalf, we are the only area increasing.
Okay, that I haven't had time to go into the level of detail, but that was my impression. And I think maybe it's something, therefore, that when we are talking to the health board, we need to, and indeed to other IGBs within Tayside, that we need to make sure that there's an understanding of where the population increase is and how services are delivered and how funding is allocated. These are probably more comments than questions. Thank you.
Thank you. Chief Officer?
Yeah, no, thank you very much, and thanks for making that point, Councillor McCall. And I can say that we will be engaging in those discussions with both Perth and Kinross Council and NHS Tayside, and emphasising the differences and the disparities across Tayside, because this is projecting and planning for the future. But the data has only recently been produced last week, and we're drawing that together. So we will be producing a pack that we can use in all of those discussions, and probably would be good to share with every member of the IGB so that you have that to hand in any discussions that you're having or future forward planning sessions within your own networks.
Apologies, Sheila. I just wanted to make further clarification when I said we're the only area that's increasing above the Scottish average. So if you were to look at this as a line graph with Angus and Dundee on, their projected increase in population, from what I recall, doesn't go much beyond the Scottish average, whereas obviously you're seeing Perth and Kinross go quite considerably above that. Just for clarification.
Yeah, thank you. I think that's quite an important point. And I just also wanted to say that Martin's points about SSID, in fact, and NRAC are absolutely crucial. We know from previous considerations last year that NRAC grouping all over 65s as one cohort doesn't really help, particularly when we have such a large cohort of over 85s. And it's perhaps something we need to make more representation to the Scottish Government to ask them to consider looking how the NRAC funding is calculated, because as we know, as people age and if they become ill, then the cost of supporting them is larger, whether they're support at home or whether it's in hospital care. So I think a concerted effort needs to be to have a good long look at the NRAC funding formula. Thank you. Thank you, Chair.
Thank you. Councillor Aidan.
Thank you. You said, Jackie, you said a wee while back that we weren't being asked to make decisions today. Do you know when we're going to have to make decisions? We can't really wait too long.
But I think that would be something that the IGB would want to have a view on. I think Councillor Elmer, yeah. And it may be that we, because our next IGB meeting is not until December, but we may want to have a focus earlier than that, perhaps in November.
Okay.
Whether that's in a budget review group or a development session followed up by formal decision making, to have a discussion about that with the Chair and Vice Chair.
Thank you.
Thank you. Martin?
Yeah, I'm going back a pedantic on this, but on population, we need to base it on health needs. You can have a population explosion of healthy people, and you can have somewhere where you're in SSID 1, and there's so much money goes into that. So you have to take both into consideration. But I do think just population exploding, it's a target with that. And I would be like Councillor Illingworth there. I would be proposing that we give the Chief Officer the go-ahead to do Part B. I think that's where we have to start as soon as possible, or it's going to come back and bite.
Thank you, Martin. Any other questions? Dave Anderson?
Thanks. Donna, thanks for clearly explaining. It's a very complex picture. Couple of comments and maybe just a quick question. I know it reflects the national picture where all the HSCP's been underfunding, which is a concern. Welcome the providers being involved, Jackie. You're in any, you're looking at Part B, any potential impact on their stability or sustainability. P&K has got a very good reputation of working collaboratively with providers and that. All the things you mentioned in your update, all the targets we've met. It'd be good to keep that work going. So I suppose my question is, obviously P&K, there's a host of partnerships before us have went down this route that you're considering under Part B. Will that be part of your impact assessment, as what the impact has been on their partnerships and their own services, what services provided, impact on providers, service users, etc. Thanks.
I think, Dave, in answer to your really important point, if we are truly thinking about what the wider implications of any change, and that delicate balance that we have across the market of services that are provided by the independent third sector and through ourselves as a health and social care partnership. We must do that in collaboration and in partnership and understand the full extent of any potential impact of any potential change. Hope that answers your question.
It does, Jackie, thanks.
Thank you. Aaron?
Thank you, Chair. Hopefully you can hear me. Just two questions from me, if that's okay. The first one, I suppose, Donna, is for you, which is in relation to the projected position. So at the moment, we've kind of noted from month 3 to month 5, there's been a circa 600k increase. And I'm just wondering, is that going to potentially replicate itself until a year-end position, or are we saying what we've got in front of us actually is the year-end position? Because I suppose there's a potential it could be an additional £1.8 million if that 600 grand every 2 months was to replicate until the end of the financial year. And I suppose the other point, I suppose making kind of connections to Zoe's paper a wee bit later on in terms of how we've looked to address unmet need across the whole service, I think has been a really important area of work that we've been involved in. And I suppose there was a bit of a spend for save piece of work that was done, I suppose, recognising if we're getting in early doors and providing those services, then actually there's less risk for those same individuals coming in much later down the pathway with higher levels of need and higher levels of wraparound support. So I suppose the question is, are there risks around the proposals in A, whether or not we might then kind of go back to a position of significant levels of unmet need and higher costs of care later on?
Thank you. I can certainly take the first question, and I would answer it in 3 parts. Firstly, yes, absolutely, there is a risk that this projection or forecast overspend deteriorates further in the year. And you'll note there is a risk section within the paper that describes the areas that we're most conscious that may affect that. That's at section 6 within the report. The second thing is to say that even if there is an increase in demand and volume and in cost of packages of care or placements that are within or under in our radar just now, if there's an increase within that, we wouldn't expect the same in-year effect as what we've already seen because there's fewer months within the year. So it wouldn't automatically replicate at the same volume. The third thing is that Part A of the financial recovery plan, you'll notice that within the elements that relate to the social care actions, we've noted plus mitigate further increases. So the intention there is for the actions to not only potentially decrease the forecast overspend as we see it now, but we are looking for them to prevent or mitigate further increases and further deterioration to the forecast position. So it's in 3 parts.
Thank you. Jackie, did you want to pick up on the second one?
Yeah, I think in terms of Part A, and your question around what will that do in terms of a potential negative impact on our current good performance, for example, around people spending less time in hospital, being discharged earlier, and therefore maintaining a level of independence that they can lose if we're not doing that. I think the actions outlined in Part A, I don't think are significant risk to that. We're very much looking to ensure that we've got an oversight and creativity and professional support to ensure that all our packages of care are the right thing for the individuals concerned. I think when you look at the measures in Part B, I think that's where those concerns that you raise begin to really bite, should we take forward some of those recommendations, because what it would mean is that those people who are currently receiving a service may not continue to get that in the future, whether to come to our attention. So inevitably those actions in Part B are going to restrict the levels of support we're able to provide within the financial envelope we have.
Thank you. Yes. Yeah.
Thanks, Chair. I think maybe just building on the Chief Social Work Officer's questions. When any proposals are brought back falling under that sort of scope of Part B, it would be interesting to see, because obviously anything that we do almost in that list under Part B is going to shift the pressure somewhere else in the system rather than simply reduce our costs. So it'd be interesting to have alongside, because I know that you'll have to do the equalities impact assessment and so on. But it'd be interesting to see what costs would be then borne elsewhere in the system alongside that. But also in terms of the issue about you know, the projected year-end number under this scenario could be worse. The position could continue to deteriorate, as I think we saw certainly in the first quarter of first quarter 6 months of last year. There's a significant sort of transformation budget available to the IJB in the council's budget, and I just wondered whether there was an opportunity to accelerate any proposals to use that money for transformation, which might be preventative in mitigating against any future increases or deterioration in the position. So something which could be used to preventatively against that increase in volume and complexity of cases.
No, absolutely. I think you raise a really important point there, Colin, and I think we as a team are considering what would be additional resource that we would require to be able to do some of that. So that would be part and parcel of the proposals that we'd be bringing back.
Thank you. Bernie?
Yes, sorry, it's just in relation to Jackie's last comment and when Part B, where obviously for me I'm looking at limit access to social care services and introduce the waiting list and just for new packages of care. And thinking back over the last few months, we've had lots of reports that have come to us where there's been a lot of work done to improve this. And I think we've had in reports about the redesign of the heart team, and it's really supported the delayed discharges. If we're looking at this, are we going to be taking a step back? And I say that in relation to linking it to support for unpaid carers, thinking about the new right to respite for carers. And yeah, so it's just a comment for consideration.
I think in terms of that point, that would be a real concern for the IJB, and it's a real concern for us and a concern for everybody who's spent a lot their professional life trying to do the very best for the people that you speak about. I think our concern would be any detrimental or negative impact on that work and the performance that we've managed to achieve will be very difficult to come back from. It'll take quite a long time to rebuild that. So I think that has to be a significant risk that the IJB faces.
Thank you. Any other questions? Okay. Can we agree the recommendations in the report? I won't read all of them, including the authorising the Chief Officer to take Part B. Agreed. Thank you. Just going back to the agenda in that case, 6.2, the verbal update on the slide. Apologies, just going back. It is my first meeting, so please bear with me. Absolutely. So we're just going back to the report. We're also authorising the Chief Officer to work with partners and request an increase in funding from partners to achieve in-year balance. Everyone happy with that?
Agree.
Yeah. Thank you. Now we go back to the Tayside Mental Health and Learning Disability update, please. Chief Officer.
Thank you very much, Chair. Just getting the right papers in front of me. It's a verbal update on our work for the IGB this afternoon. The whole system change programme has continued to focus on the model of care for adult mental health, and as outlined earlier, we hope to have a further development session on the 24th of October. And the model of care is now finalised, and there's a range of materials that's been produced that can enable engagement from a wide variety of stakeholders and audiences, and the materials will be published on a refreshed NHS Tayside web pages for mental health. We have an engagement plan produced with dates across October into December, with a series of strategic engagements with stakeholders, and that will include a wide variety of groups and partnerships within Perth and Kinross, and Jane's involved in much of that. The whole system change programme has also supported a series of collaborative conversations to hear from staff about their experiences and to get feedback on service design ideas and what matters to them in their day-to-day roles. And it's promoting awareness of the model of care and creating a state of readiness, if you like, for implementation. Two were held recently, and a further 4 have now been arranged with about 20 or so participants at each one. So I think that's giving an indication of the real interest in this and the commitment to change. And really just to let you know that Sandra MacLeod and myself as executive leads have been looking outside of Tayside, along with Dr. Peter Lefebvre, and there are two important developments emerging from that. Members of the programme board and their working groups are planning to visit areas of good practice in Birmingham and in East London in late October, early November, to see firsthand models of fully integrated 24/7 neighbourhood services, which are part of NHS England's strategic transformation of mental health services. These services are delivering integrated person-centred care within local communities. So an opportunity to visit those and develop relationships and obtain learning from those colleagues down south who've been involved in that. And that shift towards preventative community-based mental health will help us take forward the vision that we have. We're also exploring the possibility of external expertise to support the move from development phase, which is developing the model of care, into implementation. And we had a session with an organisation who that has assisted Alberta in Canada and also Wales in the UK to implement new and transform mental health services, which seems to have had pretty very outstanding results. The next meeting of the programme board is on the 16th of October, and we'll receive an update on the work that the health and social care partnerships are doing in relation to a community model for care for people with complex learning disabilities, and then update the this on the 6th of October. And at the next meeting of the IGB, that's when the next quarterly update of the Learning Disability Task and Finish Group will come forward to this IGB in December 20. Thank you.
Thank you. Any questions?
Yes.
Sandra?
Thank you, Chair. At the meeting of the Service User Reference Group yesterday, there was a question and stroke concern raised around outpatient waiting times for a mental health appointment, which the service user felt had increased considerably in their experience over the last couple of years, and was now being asked to wait 3 years for an outpatient mental health appointment. And I just wondered if it might be difficult to comment specifically, but maybe is that something the IGB could come back on, so I can feedback. Thank you.
Thank you, Sandra. Jane?
Yeah, thank you. I'm happy to take that. Sandra, it probably makes sense if we could have a chat out with committee, because I would need to understand the service that you're referring to and whether it's within the Health and Social Care Partnership or a board retained service. But I'm very happy to contact you and we can try and find a solution.
Thank you very much. Thank you.
Thank you. Any other questions? Thank you. In that case, can we note the verbal update, please?
Great.
Yeah, thank you. We'll take the next report and then have a 10-minute break. Okay. So next one is the Perth and Kinross Older People Update. Master Robertson, Head of Integrated Health and Care for Older People, to introduce the report.
Myself and Amanda are going to do a bit of a double act on this one then. Okay, so the purpose of this report is to update the IGB on information on older people services within Perth and Kinross. It's focusing on community-based care, enhanced discharge pathways and future sustainability. The work's been driven by rising demand, workforce challenges, financial pressures as highlighted in the first paper. And of course, is very closely aligned to the priorities within our strategic plan 2027. There are 3 key transformational programmes within older people that we have been focusing on, the first of which I will give you a very brief summary of, and then I'll pass over to her to look at the rehabilitation and rehab programme and integrated care teams. The first programme we're giving you a brief overview of is in relation to care at home enablement transformation. You'll be aware, and Bernie's already referenced that today, that over the last 12 months, the service has been fundamentally redesigned to improve efficiency, flexibility and capacity. Our internal teams now deliver both long-term care and reablement and are less siloed in focus and less restricted by eligibility criteria. This has led to reducing unmet needs and a reduction in our delayed discharges. We have introduced the HEART D2A, which is Discharge to Assess team, which enables timely hospital discharges. It means that people are assessed and supported in their home for up to 28 days. It improves independence and reduces the likelihood of readmissions to hospital. Multiple internal care at home teams have been absorbed to increase capacity and efficiency. Work has been done with staff to shift patterns and contracts, ensuring that we are as efficient as we possibly can be in what is quite a complex area of delivery in a rural geography. And so the work of the care at home transformation has contributed to Perth and Kinross being amongst the top 8 health and social care partnerships nationally for managing, for example, delayed discharge, and now having a very minimal level of unmet need, which is a particularly notable achievement given our rural context and our over 85 population. I'm just going to talk to you now about rehab and rehab. Thanks. So in terms of our rehab enablement programme, we had 3 key objectives around this work. It was to design and implement person-centred approach, shifting the balance of care to a community-based model and aligning the services within the integrated model, which we'll talk more about shortly, as well as trying to maintain the quality and safety of our services. Much of our work's been focused around the needs assessment, which is focused on how equitable the service is already across Perth and Kinross, what the standards of environment look like at the moment, the workforce challenges, which some of we've alluded to in the financial paper, assessment of people who've been delayed in their discharge, and as we've already discussed, the complexity, the demands we're facing, our ageing demographic and population raises. We've done a piece of work around benchmarking about what the national research will tell us, what the British geriatric standards suggest, and the best practices across the country, and considered the improvements needed around a recovery and independence and wellbeing approach. And within this, we've tried to include a home first approach as part of our Discharge Without Delay programme, in which we've collaborated with older people, carers and communities. So that sounds like a lot of words, but what that means is we've moved in terms of looking at the current model we have, and considering a tiered rehab pathway, which would incorporate a different type of bed base across into an intermediate care type model, which would be delivered closer to home and communities, and by integrated community teams. And as we progress down further options, we're now progressing to the full options appraisal, and with a timeline to deliver those options back to SVT by November and December. And as part of that, we're now starting to work up the programme of engagement that will be required with staff and clinicians and the public across the organisation. As part of our locality integrated teams, we've been working on this approach for a while now, and our ongoing developments across health and care teams and further integration. The model really looks at the multidisciplinary team approach, assessing and prioritising people to prevent further deterioration where we can, prevent admission where it's possible and safe to do so, and focused mainly on older people. Our key objectives of the project was to improve access, outcomes for people, and reduce emergency and unplanned care, and also to improve the integration approaches across our workforce. So our improvements from 2024 engagement sessions, we've worked at improving our integrated pathways. We've developed integrated huddles across health and care, including care at home colleagues. We've worked at developing shared facilities, ways of working, how we streamline our referrals, and develop the key worker roles. So we get the right person, right place, right time, first thing. Much of our work's focused around developing the hubs with the integrated teams and considering what a single point of contact may look like over time. We now have hubs in place in Perth City, and Pitlochry, Blairgowrie's progressing, and Perth and Kinross are under development. As part of our single point of contact work, we've got further work to refine these options and agree what that future model will look like. And all of that works based on the feedback that we've had from consultation through our engagement teams over the past couple of years. The paper then goes on to discuss the Discharge Without Delay programme of work and our integrated discharge hub and the changes that have been made there. The Discharge Without Delay programme was launched in late 24 and coordinated efforts across originally Tayside, Fife and Lanarkshire, and it's now a national programme of work. Perth and Kinross has been engaged from the outset and has shown strong progress in relation to Discharge Without Delay priorities and actions. We have been successful in acquiring some additional funding through the urgent non-scheduled care funding, Scottish Government funding. However, the caveat to that being that that is performance dependent. The hospital discharge team has now become the integrated discharge team, and we're keen to move it away from a hospital-based model with new roles and closer collaboration across services to expedite safe discharges. And we've introduced a care home trusted assessor role, which has reduced discharges in relation to care homes and saved 63 days in the process over the last 6 months. Beyond that, and within our communities, as you know, we are an age-friendly community and have been looking at piloting an extreme rural care at home delivery model. So the age-friendly communities approach, as supported by the WHO, is being embedded to promote healthy, active ageing and community participation. Partnered Care, community-led social enterprise model has been developed, and they are still in phase of recruitment, but with the intention to address rural inequalities, particularly in relation to care at home that the North locality have experienced. And through both of these initiatives, we've seen an improvement in older people's access to local spaces, supportive services, and an increase in their inclusion in decision making. So in terms of these transformation projects and associated programmes of work, although we're talking about them as independent areas of work, they're not. They work cohesively, and in order for us to continue to transform the way we have been, they need to continue to be able to work in that way. So when one area of this transformation is impacted, it therefore impacts on another area of that. We've got to a point in our transformation where the rehabilitation and reablement programme of work is the bit of work that we're going to spend a particularly large amount of time and focus on, and with the support of the integrated team improvement work and the care at home improvement work, we anticipate that that will be a much easier bit of transformation to work our way through. Financially, as you know, and I probably don't need to reiterate this, there's rising demand and complexity of care. present, and although additional Scottish Government funding is helping to stabilise some of the workforce, it's really quite small in the overall scheme of things, and predominantly within an inpatient rehabilitative setting. It's allowed us to stabilise the workforce there. It's giving us a bit more support and system capacity. However, and we are in a good place. However, if we start to reduce our responsiveness and our ability to react to the needs of those communities, whether they're in the community, those people, whether they're in the community or they're in the hospital, we'll see an impact pretty quickly, I would suggest. So in conclusion, older people services in Perth and Kinross are undergoing a significant level of transformation to meet the demographic and workforce challenges, to improve efficiency, to ensure sustainability. Progress is being made in key areas with ongoing monitoring and adaptation to ensure the best outcome for older people. And the IGB is asked to note progress and support continued transformation efforts as we move forwards.
Thank you. Thanks, Sam. Sam, I believe you've got a question.
Yeah, thanks for the report. It's referenced the care home trusted assessor, which sounds very exciting. But my question was, they seem to be doing great work, and what's the likelihood of the funding being extended after March 26? Because obviously they do all this good work. You'd like to think it'll continue. Is that a possibility?
It's currently funded through Scottish Government Care Home Collaborative funding, and I think the evidence, as you say, is very strong to support the continuation of that role. However, that is the funding stream at the moment, and we need to assure that that is continued, and that would be the argument that we'd be building in terms of the performance to date in relation to that. The funding's been baselined and is sitting within the Nurse Directorate, and we're in a period of negotiation in terms of how that funding is utilised.
Okay, thank you.
Thank you, sir. Sandra?
Sorry, I was just trying to find the place in the papers. Thank you very much, and thank you for that report, Zoe. So I noted reading the report, and in fact the section that Sam just referenced there, relating to the CHTA, that section included statistics on improvement, which was really helpful to see. In other sections of the report, it would have been, I would have found it much more meaningful if there had been statistics to be able to compare to. And I suppose with the financial information that we've had earlier in the meeting, that moving forward, that will be much desirable to be able to have that. Some of the statements, such as, you know, improving older people's experiences or improving health outcomes, I think it would be very helpful to have some quantification of those measurements.
Yeah, absolutely. And I think there's a mixture of quantitative and qualitative, particularly in relation to some of the age-friendly work, Sandra. It's quite difficult to quantify that, but qualitatively, based on the feedback that we get from people who are engaged in the groups and around that, the feedback's very positive. So I think a mixture of that's really helpful. I totally agree with you.
Yeah, can I come back in just for saying, so things like there are statements like in section 3.1, there are statements about decreasing hospital admissions and readmissions. So those sorts of examples, I think it would be really helpful to be able to give some sort of quantification. Yeah. Thank you.
And that is available through our performance reporting, so we can align the two.
Chief Officer?
Yeah, Sandra, I think that's a very helpful point that you've raised, and conscious that we have our first quarter's performance report coming to the Audit and Performance Committee on the 27th of October. I hope I've got that right. And quite a number of the I think the indicators in there are showing the impact of the work that Zoe's outlined today. So once that report has been finalised and into the public domain via the appropriate processes, I think it would be helpful to share that with IGMA members so that you can actually see the performance and how that's changing with the work that Zoe's described. But I agree with you that it would have been helpful to have that in here, but we haven't had it through our performance and audit and performance committee yet.
Thank you.
Thank you. Dr. Smith.
Thanks for that. It's very useful. It's more around the suggestion that we're trying to get more people out of the hospital into their own home and re-enable them there, which is great. And that improves the flow within the hospitals. By increasing the flow, we actually risk generating more workload. So is this integrated with a plan to look at how we manage that? I know we talk about reducing hospital admissions. Generally, any service that's ever been set up to have a dual role of facilitating discharge and reducing admissions rarely works because the emphasis and the priority is on getting people out of hospital. Are there plans to reduce the bed base by doing this? Is there a sort of coordinated approach? What's the future for community hospitals if this is what we're looking to do? So you're able to give some view on that.
I think that's where the rehabilitation.
Yeah, I'm just going to come in on that because Amanda and Zoe outlined the work that we've done, and also the strategic planning group received an update on this, and at its last meeting, I think it was the 23rd of September. What we're going to do is bring the proposals that Amanda's discussed to our senior management team, and from there we would be anticipating that we would bring back some of those options and a recommendation to the IJB in March. So you will get a full report on what it is we're intending to take forward and how that will change the shape of the services that we're currently delivering just now.
Could I also ask about the integrated community teams and how they link in with GP practices?
So the integrated teams are built around the cluster model, and there is progress being made around multidisciplinary team meetings, including the GP practice and colleagues. So what we are starting to see in Perth City is an operational huddle set up, if you like, where the GP can drop in with a complex case and review and share that information and ask the integrated team to do certain aspects of that assessment or care delivery. So we're starting to see that progress more in Perth City and in some of the rural areas, but that is part of the plans going forward. Yeah.
Thank you. Martin?
What has been said, that just that the 63 days to me, that's self-funding. If you're saving 63 days in hospital, what's the cost of 1 day in hospital? Mm-hmm. You're saving 63 days. You're self-funding. Opposed, but then again, the doctor said there, what is going to happen in the hospital because we are saving that. That's a point I hadn't thought about. But certainly 63 days, 500 quid or 600 quid a day for a hospital. Yeah. You're making quite a significant input. The only thing, there's only one of them, I hope they go off sick.
I think that's why we can't just look at one element. As you say, discharge is always the focus, and it's why we can't just focus on that, and it's why we've taken a whole system approach to those improvements. So there's not just one area of our delivery that we're trying to improve, so we're trying to tackle iteratively each area where the demand is coming through.
Thank you. I've got a question online from Dave Henderson.
It's not so much a question, it's more a comment. Martin, I'm presenting with the post holder, the trusted assessor, tomorrow in Glasgow, so I'll make sure I look after her and bring her back in one piece. I think that we're presenting tomorrow at Partners for Integration conference, which is Scottish Care, and then we're also presenting later on this year at the Scottish Care Annual Care Home Conference at an insight session about the role of trusted assessor. Given the profile it's been receiving from other partnerships, when Zoe asked us to look at this last year, trusted assessor has been tried and not worked in other partnerships over various attempts over various years. and there's a lot of eyes on this at the moment. The whole system's seen the benefit of the post. As I say, we're presenting on it tomorrow. Health's seen the benefit, consultants are seeing the benefit, the wards are seeing the benefits, the care home managers and staff are seeing the benefits. It's saving them time as well. The patient/resident, they're seeing the benefits. So the whole system is seeing the benefit of this post. And as I say, we are delivering these 2 presentations in the next 4 or 5 weeks, and there is a lot of eyes on this. So when I was saying earlier, when we talked about the finance paper, Perth and Kinross seen as being a collaborative partnership, this is a prime example through the bit of work that Zoe tasked us to look at last year. Thanks.
Thank you. Hamish.
Yeah, thank you. Are you able to hear me okay?
Yes.
I'm going back slightly actually to the last comment that Martin commented about hospital and the funding. When IGs were established, the large hospital set aside was the mechanism that was put in place to allow the sort of movement of funds to follow the work so that we could actually shift the resource when there was less beds needed into the community. The problem that we've got is that there's an increasing demand right across the system. So just standing still within the hospital system and having a static number of beds is actually massive progress, because we've got this demographic rise and this increased dependency. So it makes it very difficult to move that bed cost back out into the community. And I don't think we've succeeded in doing that in any meaningful way over the last 8 to 10 years.
Thank you. Okay, any other questions? Anyone? Okay. So no further questions or comments. Can we agree the recommendations in the report?
Agreed.
Yeah, thank you. I think it's an opportune moment to have a break. If we come back at 8:45 Okay, one on the agenda is primary care strategic delivery plan. Hamish, I believe you're going to be introducing this.
Yeah, just very briefly, thanks, Chair. It's been a busy year for primary care. There's been a number of developments, a number of progresses, particularly on lease fronts and successful tendering of the CARS practice, which we're all delighted to see. So I'm going to hand over to Sal, who's our lead GP within the partnership, and she's going to give you a brief overview of the documents. Thank you.
Thanks, everyone. I've been asked to keep this short and sweet, which people who know me will see that that's a bit of a challenge, but I will do my best. So I'm really pleased to be presenting the annual update for the primary care strategy. This is now in the second year for both of the documents. When the papers went in, it was before we actually knew much about the transition of CARS, and so I would like to just spend a few moments just to highlight how successful that has been. We have, as the primary care team, spoken to patients, staff and also their partners, and it seems to have been a very positive transition with very little difference in the care that's being received from how it was a few months ago. So that all seems really positive at the moment. With regards to strategic outcomes, we've made progress across all 3 of the strategic outcomes. For people, we've been particularly focusing on access, engagement and experience. We held a primary care connections event in September that brought together about 120 staff, both from GP services and managed services. And this really fostered collaboration, along with being able to showcase some of the third sectors that can really help contribute to care within primary care, such as PCABs, Mindspace and Neurocentral. We've highlighting CTAC service. This has delivered over 137,000 appointments in the last year, but we are aware that we need to think about the utilisation rate. This is about 71%, but there's been some really positive work around data cleansing, using dashboards and also wider mapping of services that will help with that. We've also now got within the CTACs, we've got ECGs, wound care, diabetic reviews, and we're also preparing to launch the paediatric phlebotomy and wound service within the next 4 weeks. And we're also optimistic that we'll have extra diagnostics such as spirometry soon. We're also got have ongoing support for other patient-centred incentives, such as the REPEC plans, which support personalised and emergency care planning. Within the workforce, we acknowledge that GP sustainability remains a key risk, particularly around workload, premises and recruitment. We're very lucky in the fact we've got sustainability services and quarterly indicators that help to identify practices at early risk, particularly highlighting those who may be quite vulnerable at the moment. It is worth knowing that at the moment there's been a drop in locum reliance and a decrease in GP partners planning to leave within the next 2 years, which is really positive. We've also been able to identify that there's been an increase in additional roles to support within GP surgeries. The protected learning time has been re-established, and we're now offering sessions on asthma management, things like suicide prevention. There's been care navigation, and we're also keen that we've supported the new GP nurses with tailored drop-in sessions and education. For the system, we've had a really positive DOAC switch, which has led to about $500,000 in prescribing savings, and a big thanks to all the practices who did take part in that, and it was over 2,000 patients reviews that were completed. We've also been able to contribute to new asthma and diabetes pathways, and we've now got an expanded QSEP team who are helping to improve efficiency and also look at what new projects can be undertaken by practices. Digital progress has been a little bit mixed. The vision migrating was disrupted because there was problems with the supplier insolvency, although we did have 1 out of our 2 practices go over to vision before that happened. We know that there has been a pause on new digital requests until April next year. However, we're still using consistently innovations such as MedLinks, and I think it's about 5 practices are now using the Think Healthcare telephony, which is really improving patient access and efficiency. Just coming on to the managed services, which we continue to support and develop as part of the GMS contract from 2018. I think each of these play a vital role in enhancing access and improving outcomes. However, we do have to acknowledge, as Audit Scotland did, that there are some challenges around the implementation of this, particularly around finance, staffing and premises. We've mentioned about the CTAC service earlier. This has now had a transition into central management, which has improved consistency in government. However, we are struggling with space, particularly in places like Drumha, which is limiting further expansion. And as I said, there's an ongoing review of the model and the leadership structure to support how we can grow that further. The primary care mental health and wellbeing nurses have seen about 4,500 patients in the last year and have had a real improvement by introducing a band 4 support workers, particularly in Perth City and the south of the locality. And that's really given patients access to be signposted to other services or activities that will complement their wellbeing. This service is now really well embedded and gets really good feedback from practices, but there are ongoing staffing pressures. There is plans that hopefully, if we can get the funding, that this band 4 model will be rolled out more widely, and we'd like to look about how we can integrate things like the wellbeing team into social care teams. The social prescribing has done exceptionally well in the last year. It initially had a really high waiting list of over 140, and recently that's decreased to over 28, and they've managed to decrease the waiting time on their list down to 2 weeks, whereas before it was quite a lot longer, and they're aiming for 48 hours at the moment. So that's something really positive by introducing a duty worker. The urgent care and home visiting AMP service, which at the moment is helping support frail and housebound patients with deteriorating health, is expanding its reach and resilience. We have that well integrated within the team that was mentioned earlier for care of the elderly, but we're hoping to recruit that further. there's been a test of change, particularly in Perth City, and we're optimistic that that can inform future models for the north and the south. First contact physio is really well integrated and established at the moment, and that is really well valued by colleagues. The GP clinical pharmacy service has had its challenges, particularly in the last few months, particularly with recruitment and sickness, which has resulted in very limited resources. But they really have shown resilience by looking at how they can work differently, opening a second pharmacy hub within Perth to support staff pressures, and they continue to collaborate with practices to see how they can improve further. And I was really pleased that the last week I saw that our pharmacist had actually come back into our practice for the first time, which was great to see. And finally, we've got the vaccination service, which although is not directly managed by the Health and Social Care Partnership, this is done by NHS Tayside, but I think we have to recognise that this is still vital for components of our population health. Would you like me to carry on for the SDP or the strategy, or would you like to take questions at that point?
Any questions?
Yeah.
Anybody has at the moment for that report? Any questions from anybody before we move on? No, I can't see any. No. Please continue, Sal.
That's excellent. Always good news. So we'll move on to the primary care premises strategy. I think we have to recognise that we have made a lot of progress within this, but we have to acknowledge that this remains critical for sustainable primary care delivery. The key achievements from this year are we've had lease assignations. So we've now progressed 5 lease assignations, 4 of which have been completely improved and 1 where we've just pending financial assurance. But there'll be ongoing work around that for further lease assignations that are coming in the foreseeable future. Obviously, Cars Medical Practice, we're all thrilled that that's been successfully transitioned over. The lease assignation and health needs statements were completed, and we continue to explore permanent premises options with that. And I know that having spoken to the partner yesterday, they're keen to ensure that that's a collaborative approach. We continue with improvement grants to support upgrades across practices, including heating systems, LED lights, patient areas, and these improvements really contribute to efficiency and enhance patient experience. We did do a premises service that you might remember a few years ago, and we used what's said in that to highlight areas of improvement, which is about access, signage and privacy at reception. For strategic planning and infrastructure, we've strengthened collaboration with P&K Council. We've contributed to the LDP3 evidence report, and we're submitting calls for sites in both Errol for future GP surgery. We're actively involved in the Tayside Wife infrastructure planning group to make sure that we're considering healthcare needs when we see that there are new housing developments. And so far, we've responded to 5 major planning applications to ensure that this is being considered. However, there are ongoing challenges with regards to this. We've got capital investment constraints, premises capacity is an issue. So we talked in the last paper about the managed services that we provide, and it's problematic when we can't get them working close to the GP surgeries. And there are still some lease assignation risks that remain quite high, as there seems to be concerns about the capital funding. So our next priorities, particularly for 2025 and 26 for the strategy, are about continued lease assignations, thinking about how we can contribute to the discussion around developer contributions for primary care infrastructure. We're going to think about how we can establish working towards options for Perth Western Edge, and we're going to complete a service mapping exercise of all our services so that we can identify where our services are and where the needs may be greatest. Thank you. Any questions?
Thank you. Any questions? on either report? No. Thank you. Thank you. If there's no further questions or comments, can we bring? Oh,
Yeah,
sorry,
I have a
Councillor
question.
McCall. Sorry.
Thank you. Thanks, Sal. That was a really good update. I think the question really I have, or maybe it's just a commentary, I'm not sure if you'll have an answer, but based on the latest information that we've received in in terms of population growth and spread, I think how can we take that information and overlay it into what we're currently doing? And I think the current strategic delivery plan only lasts out to 2026. Is that correct?
Yes. So it's something that we have to start thinking about very soon. And I think you're absolutely right. When we've seen that huge increase in the population, we really need to consider about how we're going to adapt and change to incorporate those health needs, and that'll be something that we'll definitely be considering in the next strategy. There are areas that we've been able to link in with which have been really helpful. So the integrated team, which looks at how we can link urgent home visiting from GPs into addressing the wider health needs of our older and frailer population, which has been successful in Perth City. So there are key bits that we need to look at to be able to work collaboratively as a whole system as well, to be able to support the changing populations.
I think that's really important, and I think it kind of links to the premises strategy, because I think we need to understand as well, where are these this population growth going to be living? Because you can see from your report that there's been a significant increase as some of the peripheral surgeries or practices have closed down, the satellite ones, and there's a significant increase in some of the Perth City practices. And I do know, just from, it's one of the biggest postbags I get, is people just commenting that they can't access their GP.
Absolutely.
And it does put people off going when they should do until they're absolutely desperate. And of course, by that time, perhaps their situation has progressed to an extent that could have been remedied earlier. But I'm also mindful that if our population of over 85s or over 65s is increasing, we need to give some consideration to the distance and the accessibility of services for them. So, like I said, this is more a comment rather than, I don't expect you to have the answers right now, Sal.
So no, absolutely. I think we recognise, as do most of our GP colleagues, about the increased demand and how it will affect their day-to-day work and their population. I think everyone's aware of that, and that's why it's so important that we have things like the sustainability, but also keep collaborating with our GPs to look at innovative ways that we can enhance that demand. We are looking at areas about how we can move out services to see into areas that maybe don't have the same access. So, for example, you might have read in the report about the Bridge of Erne. So Bridge of Erne now has a variety of other services available, such as drop-in wellbeing. It has the C-tax. We get social prescribers up there. So we're certainly looking at how we can diversify the where our services are.
I think the other question I had, just following on from that in terms of the premises strategy, I know that at NHS level, the property team work quite closely with the Perth and Kinross property team to try and create one public estate. But I think particularly in our rural areas where we have community campuses, and there is space on those campuses as well in terms of perhaps land that's owned or capacity within the facilities. So I'm just wondering how much engagement is there with the property team in Perth and Kinross when we're developing a premises strategy for primary care?
There's certainly increase since we developed this. There's certainly increase in collaboration and support on both ways with Perth and Kinross Council. We've also got really positive links in with NHS Tayside at the moment, and these are meetings and resources that we've been building up as this strategy has gone on from year to year.
If there's anything I can help, if there's any blockages in Perth and Kinross Council and I can help, let me know.
Thank you. That would be gratefully received.
More than happy to try and help with that. Thank you, Chair.
Thank you. Thanks, Councillor McCullough. Sandra, please.
Apologies that I was a couple of minutes late coming back from coffee, and apologies then if a couple of questions if they've already been covered. So I noted that concerns being expressed about premises seem to be excuse me, about GP premises did seem to be something that was increasing, and that's obviously of concern to see that is happening. On prescribing and some of the prescribing initiatives. So that's great to see that those are having a positive impact. And I wondered if there has been an opportunity, or if there might be an opportunity in the future, to go back to patients and ask how they found, what their impression of the switch was. Was that a positive experience for them? I thought that might be helpful in general terms to understand moving forward. And I noted that there was a comment about the digital transformation being paused, the digital engagement request pathway, and I just wondered if there was any insight available into that and why that was. Thank you.
I'm afraid I don't know why particularly the digital aspect has been paused. I don't know if Hamish or Caitlin know.
I suspect it's financial restrictions.
Chief Officer?
Yeah,
okay.
As part of the Chief Executive's team, it was really just to say, Sandra, the digital service and has been oversubscribed in terms of requests for development for a significant period of time. So in order to prioritise that and focus and target the work, they've had to put a pause on all new requests. So that's the reason behind that. So I suppose that does boil down to a finite level of funding and resource to support it.
Okay, thank you.
If I can come in just about the prescribing incentive and the patients, that's certainly something we can look at. However, what we actually find is because it's the GP practices that are actually undertaking these reviews, that they often have close contact to the patients that they're discussing this with, and also often we find that we will get feedback at the practice. So, for example, I did my practice and there was about 80, and we didn't have. And none of our patients had any concerns at all. In fact, they were really quite positive about it because they acknowledged that of the difference between the cost and what a benefit it might play to the NHS in the long term.
Yeah, thank you. I mean, I wasn't necessarily expecting it to be negative. Where it's positive, it's good to hear that as well.
Thank you.
Thanks.
Martin?
Yeah. Thanks very much. That was a really good report, and I just wonder how positive that report is. How do we communicate that with people across the partnership area? And there needs to be, I think we missed a trick in here about actually putting forward all the good stuff that's going on. And I know I've got a role in NHS Tayside about communications, and we start it every week putting out 5 positive things that have happened in the area, and there's a lot of positive stuff coming out of that. It needs to go out and public to understand what is really happening. That would be a wish for me, but the one that I've got is on page 79 and 126, and it's about the lease assignations. And colleagues are working collaboratively with the NHS Tayside Property and the Department Assets Management to clarify the process. And is there a timeline on that? I do think it'd be rocket science to clarify a process, and I wonder why it would take so long.
Caitlin might be able to answer that because she's heavily involved with the premises group with NHS Tayside.
Thank you, Sal. Good afternoon, everybody. Yeah, thank you for your comment about the lease assignation. So it is a lengthy process in the respect of From the primary care team's perspective, we have to develop a statement of need for each practice who has sought lease assignation from the Chief Executive's team. We prepare a paper for the partnership senior management team. It then goes to the primary care premises group. It then has to go to NHS Tayside's asset management group, and that's where the financial ask is of that group. So as the report has said, we've had feedback from 4 of the practices now that financial assurance is in place, and we're just waiting for 1. And I think it's just worth remembering, colleagues, that this obviously is a new process for everybody, the lease assignation. I think there's only been 1 that's been running alongside the 4 or 5 of ours in Perth and Kinross that's been undertaken in Dundee. So it's learning for the whole organisation, including the property and asset management team, who I have to say have been excellent at working alongside with us as we take this forward.
Thank you. Chief Officer.
Yeah, I would just like to say to congratulate the team on the work around the lease assignations, because you've kind of broken a mould, I think, Caitlin, and done some work, and that's not to diminish the work that sits behind all of these reports, but the quality of the information has made the decision making easier. So although you describe a complicated process, I would just like to congratulate the way in which you've navigated that and how you've managed to get to this endpoint so far. So thank you.
Thank you, Jackie.
Thanks, Chief Officer. So if there are no further questions or comments, can we agree the recommendations of the primary care strategic delivery plan and the primary care premises strategy? Agreed. Agreed. Thank you. Thank you. Next on the agenda is the Perth and Kinross Health and Social Care Partnership User Plan. So I think this needs.
So the purpose of this paper is to give you an overview of our winter plan for 25-26. So it outlines the approach for managing increased pressure within integrated health and social care within Perth and Kinross during the winter, focusing on maintaining capacity, optimising patient flow and supporting vulnerable populations. As has been discussed numerous times today, we have rising acuity and dependence across all care settings, compounded by an ageing population with challenges. The winter plan focuses on maintaining people at home whenever possible throughout the winter and optimising flow through the hospital to ensure there's enough capacity to provide inpatient care for acutely ill people as required. The paper's framed around the Scottish Government winter plan priorities, which are prevention and community care, right place, capacity and integration, and workforce wellbeing. Reference the service, I won't go over it again, but the paper makes reference to the discharge without delay and additional funding that came into the Scottish Government with the Urgent Non-Scheduled Care Board. There has been no additional Scottish Government winter funding this year, and the only funding that we have had is that Urgent Non-Scheduled Care funding, which has stabilised the existing workforce that we have rather than adding additionality. The funding is performance and allocated to rehabilitation, small amount to advanced practice within communities. The slippage is being used to top up our care at home provision. In terms of business continuity and resilience, there are plans for adverse weather, power cuts, increased demand and outbreaks of viral infections, respiratory infections. Actions include securing transport, updating continuity plans and maintaining critical services. With regards to stakeholder engagement communication, we're ensuring consistent messaging to the public and partners regarding accessing care and using Scottish Government's Home First toolkit in collaboration with our communication teams. In terms of staff wellbeing and culture, we're encouraging our staff to uptake vaccinations, share information on how they can access that, and ensuring community staff have appropriate warm, safe uniforms for the winter period. So the plan provides a strategic and an operational framework to manage winter pressures, prioritising prevention, early intervention, system resilience within available resources. We're currently in a stronger place than we've been in a significant period of time as we head into winter with a low level of DDs and unmet needs, and we should take some reassurance from that. And the key recommendations are that we note the ongoing capacity and flow pressures likely to intensify over the winter period, and that we endorse the Perth and Kinross Health and Social Care Partnership Winter Plan and its alignment to the wider Tayside plan.
Thank you. Any questions? Sir, Andy?
Yeah, so I appreciate it's all about delegated services, but there's not a single mention about general practice within the winter plan. And do we feel we're missing something there? I mean, general practice cope with huge increased demand during the winter months, no additional funding. And it might be useful for future plans to just have some reference to what's going on in general practice and primary care as a whole within P&K, even though primary care is not a delegate service as such. What do you think?
I don't have any particular objection to that at all. And it's part of a system that needs to work together. So I think it makes sense to include that in there, Danny, definitely. I don't see any reason why we wouldn't do so.
Martin?
What is the extent of the winter plan? What is it? Because we're in Scotland, you've got winter and you've got June. What is the length in the winter plan?
Well, we had our first storm last weekend already, so and I think that's the growing argument that winter is no longer winter anymore, and we're experiencing that increase throughout the year, and not necessarily even at winter specifically that you might traditionally define as winter, but really from now onwards. That's why the planning starts as early as it does, right through until probably next March. Yeah. For half the year.
Thank you. And so, Sheila, please, Councillor McCall.
Thank you. I'm not quite sure who I should be asking this question of. It's maybe Zoe and maybe it's Sal, but I'm just wondering about the winter vaccination programme and if we have any indications of the uptake of the winter flu jag in particular. Do we know if that's been taken particularly by our older residents?
Chief Officer?
I think it's only just started, so I don't think we have any data at the moment.
Okay, thank you.
But we should be able to get it, and it's something that we keep a close eye on. I noticed that all the posters have gone up to encourage people in the surgeries, so hopefully we'll have some more information soon.
What's what I'm really thinking? I mean, I've been in and out of Pillar House a few times, and it always looks to be quite busy, and which is good. But I'm also mindful that I often recognise people in the queue waiting, and they're all city based. So I'm just wondering if there's any kind of demographic, not just age demographic, but geographical spread of the uptake of this.
Chief Officer?
Just a couple of points, Councillor McCall. I know from visiting the vaccination centre, although we're not responsible for the delivery of that sits with public health, and I see that Heidi's just left the meeting, which is unfortunate. She may have been able to answer some of your questions, but they do go out and do locality visits, and they do home visits, and they do care home visits. So I know it's not all based within the vaccination centre in Pillar House. I think the point you raise is important to recognise here and emphasise that the communication in terms of promoting the uptake of the winter vaccinations is something that we should be continuing, not as a one-off thing, but throughout the winter. And we've built that into the Perth and Kinross Council's communications plan as well. So you might have seen that coming out on the council's social media as well as NHST side. So we'll continue to reinforce that in all of our communications.
It's probably,
okay, thank you.
Like you point out as well that it's just flu vaccinations for health and social care staff, not COVID as well.
Any other questions? No, if there are no other questions or comments, can we note the report and the recommendations? Thank you. Next on the agenda is the strategic planning group update. Chief Officer.
Sure, I'm happy to give away the updates and noting that Nettie Sutherland is not in the meeting. So, but there was a meeting of the strategic planning group on the 23rd of September, and that took place online with another meeting planned for the 25th of November, which will be an in-person meeting, and actually just incorporating the new arrangements for more face-to-face discussion and collaboration and encouraging relationships between stakeholders and a variety of managers and staff. So the last meeting, there was a review of the current terms of reference, or that was commenced, and a commitment to the joint chairing arrangement, which was not within the terms of reference. So that will mean that we will have within the refreshed terms of reference a co-chairing agreement between the chief officer and a public partner. A key action from that division was to ensure the re-establishment of our local strategic planning groups or locality planning groups in each of our 3 localities, supported by our locality managers, service managers in the north, south and city. The strategic planning group received summaries of the 2 primary care papers that have just been considered by the IGB, and there were 2 presentations. First of all, from Zoe Robertson in relation to the direction of travel for older people services, and Amanda Taylor, who's here today, on the rehabilitation transformation programme that we've heard about today as well, and that move from inpatient to community-based rehabilitation. And that presentation featured quite a comprehensive analysis of data and research, and also has begun to sort of put a diagram around what I would describe much more of a model of care for people across Perth and Kinross. So the options will be taken. There'll be an options appraisal carried out in relation to that, and a recommendation on those options will come back to the IGB in March 26. So that was the key items that were considered by the strategic planning group in September. So thank you very much, Chair.
Thank you. Any questions? Thank you. If no further questions or comments, can we note the verbal update? Agreed. Thank you. And then we move on to 7.2. Performance committee update. Can I ask Councillor?
That's me.
McCall to provide an update, please.
Thank you. Firstly, I want to thank Sandra Auld, who's taken up the non-voting public partner vacancy on the committee. So I'm now happy to report that we now have full representation from all partners. So thank you very much to Sandra. The IGB Audit and Performance Committee last met on the 29th of September 2025. This was a single subject meeting to approve the audited annual accounts, and a link to the papers are included in the agenda for today's meeting of the IGB. Audit Scotland representatives attended the meeting in person to present their findings to the committee and to answer any questions from members. I'm not going to go through the whole report because you have a link, but there's 1 or 2 parts I would like to perhaps draw out to your attention. They found, quite crucially, that the financial statements give a true and fair view of the financial position of Perth and Kinross Integrated Joint Board at the 31st of March 2025 and the transactions for 24-25. And that the methodology, significant assumptions and data used in making accounting estimates are reasonable and have been properly reflected and disclosed in the financial statements. I probably should caveat that now by saying it's before the latest population projections came forward, so we may need to look at that again. There was a couple of significant conclusions I think that were worth noting. They were satisfied that there is no material misstatement due to management override of control, and that Perth and Kinross IGB has worked hard to secure additional funding for 25-26. However, the financial sustainability risk remains significant, and service redesign and transformation will be key to developing sustainable integrated care. They also noted that Perth and Kinross's IGB's financial management reporting arrangements are effective, and that the IGB recognises that addressing the significant financial pressures will require further funding, strengthened collaborative working, strategic planning, robust financial management, and a reserves policy and effective workforce planning. There has been a recommendation that the IGB needs to use its strategic commissioning role to work with partners and other service providers and service users to accelerate service redesign and transformation to provide sustainable integrated care. We recognise that this will require additional capacity or reprioritisation of resources to deliver this effectively. The auditors concluded that governance arrangements remain appropriate and support effective scrutiny, challenge and decision making. The strategic plan for 2024 to 27 provides a clear vision for health and social care services, strong collaborative leadership and additional capacity or reprioritisation of resources is needed to deliver Perth and Kinross IGB's strategic aims, including service redesign to ensure sustainable integrated services. And that Perth and Kinross IGB continues to perform well, with 11 of the 12 indicators reported in 24-25 exceeding or being within 3% of the prior year's performance comparator. For the indicator out with this range, performance is better than the Scottish average. Workforce recruitment and retention remains an issue nationally across the health and social care sector, but Perth and Kinross IGB is taking action to attract people into care as a career. It's currently updating the workforce plan for 2025-27. So that was some of the key findings from the auditors. And as already mentioned by the Chief Financial Officer, that while we have a clean set of accounts for 24-25, the challenges we are facing in Perth and Kinross IGB are also being faced across Scotland. And that while we compare favourably to our comparators and generally to Scottish averages, there's still quite a lot of work to be done. The Audit and Performance Committee, therefore, will continue to closely monitor performance, both operationally and financially, to ensure we continue to deliver services in the best way possible. The next meeting of the Audit and Performance Committee will be held on the 27th of October 2025. Papers should be available to publicly on the 20th of October, and as always, members of this IGB are welcome to attend. Thank you, Chair.
Thank you, Councillor McCall. Any questions from Councillor McCall's report? No, don't think so. Thank you. If no further questions or comments, can we note the verbal update? Thank you.
Thank you.
Thank you. Next on the agenda are the reports that are presented for information. If anybody has any questions. Okay, thank you. The next meeting is on Wednesday, 17th of December. Thank you very much. I think that's it. So just for members that are present, we spoke in earlier about a date in November, just in case we needed to bring anything forward. Would you like to?
Yeah, I'm not sure if that would be a development session that we could have with all IGB members, and I guess it was just to say before we close the meeting that that's maybe work that we need to do with county services to try and work out if there's a date rather than wait until the 17th of December.
We'll do that. Thank you. Thank you, everybody. Thank you.
Thank you.
Thanks very much.
Sam has a question or a point to make, Chair.
Sorry.
Yeah, but Brian, I just noticed that the next meeting is the 17th of December. That clashes with Angus for Martin and I. Okay, we'll have difficulty doing the two meetings, much as I'd like to try.
We'll look at Sam offline. Thank you.
The Christmas cake twice so.
Thank you, everybody.